Good morning, ladies and gentlemen. I'm excited to be talking to you about a topic that many of you may have never heard of, untrustable professional activities. And I hope after 20 minutes, you will at least have a sense of what that is and how you might be able to use it as a focus for learning, teaching, and assessment of learners and professionals. I have no conflict of interest to be reported. The overview of what I will be talking about has 6 topics. One is just to define the untrustable professional activities as a missing link between competency-based medical education and practice, actually. And then the second question is, when is a trainee competent? Third is, how can EPAs serve curriculum development? How can they serve assessment? And how can they serve learner participation in practice? And finally, how can they serve for maintenance of competence? So competency-based medical education, and I'm pretty sure that most of you are aware of that, has important philosophy. The philosophy of competency-based medical education that we have seen growing in the past 20 years, I would say 2 decades, is that we are trying to make a better description of what a doctor is and actually better define what a competent doctor is. And subsequently, of course, we only want to graduate people who meet those standards of competence. And if we really seriously think about that, we must realize that individuals are not identical, as we have actually treated them for maybe hundreds of years by saying there's this period of training, and we know that all people are probably above average on the last day of training. But basically, we actually know that individuals vary, so maybe we should also look more individually at curricula for individual persons in training. Now, in practice, using frameworks as the competency-based framework of CanMeds, and I think you're familiar with that in Australia, what you can see is a rather detailed description of those competencies, and we now have experience that people sometimes struggle with teaching and assessing those competencies of physicians. And why is that? And that is because if we look at our frameworks for the description of those competent doctors, we of course start with the holistic general idea of a doctor, and we have to break it down if we truly want to teach and assess those people. So we think of 7 roles, but if you look at those roles, it's not easy to assess doctors on each of these roles because they're still too broad. If we think of communication, there's a lot of different types of communication. We have to all take those into account. And then if we just take communication with patients, it may still not be granular enough because there's so many different types of communication with patients. And what we end up with is really a framework of many, many elements. This is the new version, or this is actually not even the most newest versions, but this is a version of the CanMeds framework that was designed in 2005 with 134 elements, 28 key competencies, and 125 enabling competencies. And not a regular physician would not remember all those elements. So it is not very easy to evaluate learners on all those elements. And that you can read back in the literature. Well, many of the countries and regulators, and my country too, we have adopted in the Netherlands the competency-based framework of CanMeds. But still there's people that are critical about that whole approach. And you can read articles in the medical education literature with titles like this. And the question really is, do these people have a point or not? What is actually the problem? And if you look at it, the problem is very often not very fundamental in the sense that people accept the framework, but they have difficulty with the implementation of it, with the details of teaching and assessing. And so my proposal is, why don't we go back to the most fundamental questions and rethink how can we restructure our definition of competence and our training accordingly. So go back to the foundational questions of what is the work that must be done? When do we start trusting our learners to do that work? And how do we prepare our learners to be trusted with unsupervised practice? Then how do we evaluate their readiness for it? And finally, which competencies are needed if you would like to trust them to do the work? So not start with the competency, but start with the work that must be done. And here we come to the concept of entrustable professional activities. One definition is that an EPA is a unit of professional practice that may be entrusted to a learner to execute unsupervised once she or he has demonstrated the required competence. And EPAs, the concept EPAs was really coined to create a grounding for competency-based medical education, to see how we can connect those somewhat theoretical frameworks of competencies with what happens in everyday practice. So again, if you see the distinction between competencies of physicians and practice of work, they are very different types of concepts. On the left, you see competencies are really descriptors of persons. Persons have qualities, features, characteristics that make them suitable to do the work. And on the right side, you see EPAs are no more or no less than a description of what that work is. Parts, units of professional practice, things that must be done tomorrow morning. If you think of your own practice, you could start thinking of EPAs if you just start with your calendar Monday morning at 8 o'clock. Just think of what happens in your practice, and then think of what type of learners do we need, or type of professionals do we need to carry out that work. Could be discharging patients, could be inserting a central line, could be resuscitating a patient if it's needed. And basically, so we have two elements. One is the EPA, that's the task that must be done. And then we look at a person, do they have the profile that is required to do that work? Do they have the competencies to be able to do that work that require those competencies? And basically, if you look at it that way, competency-based medical education can be viewed as a matrix with two dimensions. One dimension is all those competencies, and here they're only mentioned as the Canadian CanMed's roles. But then also the other dimension is the tasks that must be done. So the EPAs. Here's EPA 1 to 5. Now, if you think of it, almost anything that you can think of in your practice of healthcare requires people with multiple competencies. It's not just communication, or it's not just physical skills that people have to do, or clinical reasoning, or professionalism. It's usually the combination of many things at one time. And this is what this grid actually shows. And that is the way you could look at learners and assessment of learners. Just ask them to do things and look at the combination, the integration of all those competencies, and use those EPAs and trustable professional activities of work to focus your assessment on. And if you have a program for learners that maps all the EPAs well, at the end of the day, you would probably conclude, if you've seen that they can do that all, and they have integrated those competencies that are all important you don't have to measure those competencies separately. You could just infer that they are present. So basically, the approach with using EPAs combines all those competencies into the elements, the units of work that you do. It's more of a holistic, synthetic approach. So again, what is an entrustable professional activity? It's a unit of work that is executable within a time frame. It is observable and measurable. You could sit next to somebody and just look how they do, or you could hear it, or you have another way to evaluate that. You can think usually of tasks that must be done and allocated are to individuals, and they are suitable for entrustment decision. There must be one moment in a training period that you would be able to say, now you have demonstrated enough competence to be able to do this unsupervised from now on. And usually tend to say that at the end of a training period. But basically, if we look at competency-based medical education, what we want to do is certify people for the competencies, and most of them might be reached earlier than the last day of training. And some might not be reached at that moment, and you might have to extend training. So we're looking much more at what people can actually do in a competency-based medical education program using EPAs than just assume that they are ready for practice at the end of their rotations. So again, EPAs are entrustable, which means that the acts that they do require trust by colleagues, by supervisors, some also by patients, and maybe by society as a whole. They are professional, so EPAs are always those things that are confined to occupations with an extraordinary qualification or right to do. Not just anything that even a doctor does I would call an EPA, but those things that are really part of professional practice that requires actually permission to do. And then it's activities. It is tasks that must be done. Now, second is, when is a person competent? What is competence, and when is one? When is one competent? And a simple definition is when a professional activity is mastered on a threshold level that permits trust to act unsupervised. And in that sense, you can see competent as a stage in a continuum of development. And if this is the graph that shows that development, and horizontally is the time, and vertically is their competence, you could evaluate people on stages of their development, starting with a novice stage, and people usually learn very quickly in an early phase, have a fairly high level of competence already in the first months of training. Then it levels off a little bit. Second level could be called advanced beginner, according to a framework that was designed by Dreyfus and Dreyfus in the 80s in the United States. The third level is what they call competent, and there's a fourth level proficient and a fifth level expert. Now we know that people, even after training, will keep on developing. So it's not an end stage. And even though we know that all our graduates are above average, we know still that they will keep developing after training. So the competent is a nice word in the middle of that development. And actually that moment, that pivotal moment that we would say, now you are ready for unsupervised practice. And almost by definition, that would be our training period. Because afterwards, we can call those persons our colleagues because we have observed that they are competent to do that work. Now, if you think of competence in general, you could also think of competence as split and different EPAs. Of course, they are ready for unsupervised practice here. Now, if you think of a trainee, you could think this trainee has this same curve for EPA number 1, but there could be another EPA that would be steeper, you could say, or easier in another way. So at an earlier stage, people could have a higher level. There could be another EPA, another part of professional work that they don't even start in the first year of their training with. And there could be something that's even easier, or there could be something that people show already some preparation before they go to their training period. And if you draw that same line of the threshold level that would permit trust to work unsupervised, there's different moments in training that you could actually signify as the right moment to trust that person to work unsupervised. And if you think it that way, competency-based medical education really looks at when are people, specialists in trainings particularly, ready for unsupervised practice as not something that happens on the last day of training, but during the training at that moment that you really have observed they can do. And then they can start being your colleague. Now there's one interesting curve here also that you can see. that actually if you define that level of trust, it could be that people, after they have finished their training, never practice anymore. And it would be no more than logical to actually say, maybe people should lose our trust and fall back on a stage that they are not permitted anymore to work unsupervised. Now I've been talking about the distinction between unsupervised and supervised training, but you could make that more detailed as a framework for supervision. Starting with one level, the lowest level would be level 1. The people would be present, would be permitted to be present, but not have permission to act in that EPA. The second level would be that people would be allowed to enact that EPA with direct, proactive supervision of a supervisor in that room. You could say to a learner, you can do that as long as I'm present and I can take over if it's needed. And I determine how much supervision I will give you. Now, the third level is distinctly different. That is actually the level with indirect supervision. So you would say to a learner, you could do that, I'm not in the room, and then I trust you already to ask for help if you need help. And if you need help, you'll get that immediately, because that's this third level, defined as there's immediately help available, but reactive. So you react to a request for help if it's needed. And then level 4, as we call level 4, is that level of unsupervised practice that actually reflects the end of training that you expect people to have before they go to unsupervised practice. And that's that same threshold level that we called competent. And there's even a level 5 that you can envision that people are experienced with that EPA and would be able to provide supervision to junior learners. So if you think of it that way, the EPA approach serves the flexibility that competency-based medical education actually requires, because it acknowledges that there is differences between trainees, and there's also differences between EPAs within one trainee, and there's also variation of context. And if you don't all take that into account, the conclusion is that you really, if you want to educate physicians to be competent in everything that they must be able to do, that you must individualize somewhat. And there's not one size that fits all trainees. So using EPAs may change your view of competency-based medical training and practice. For one thing, the curriculum could be different, as it is more individualized, but it has more clear targets. Assessment could be different, because we talk about entrustment decisions instead of just observation and scaling someone on a scale. We also talk about legitimate participation of trainees in the community of practice, and you could even think of EPAs as having a role in maintenance of certification or maintenance of competence. It might be helpful in re-registration. Let's touch on those 4 elements and show you some examples. If we think of curriculum, an individual curriculum using EPAs in a competency-based framework could look like this. Here you have these same 5 levels of supervision, and you could say that the portfolio of trainee Jones looks like this. There's 4 years of training, and there is here 4 EPAs, and you could see those levels of training move across that training period. And here's level 4 reached at different moments for different EPAs for this trainee, and from which moment on this trainee would be allowed to work unsupervised, at least within a training period. So there should be some oversight supervision, but not the type of supervision that requires direct availability of a supervisor. Now, the assessment of learners could be different if you use EPAs. Entrustment as assessment basically combines not only the evaluation of ability, but also the recognition of a right to act and also a duty to act at a designated level of supervision. So if we use that phraseology of making an entrustment decision instead of saying this learner is worth A, B, C, D, or on a 10-point scale, that makes a difference. And just think of it as a different framework for assessment. And it's more than the traditional workplace assessment. So summative entrustment decisions that we recommend to take that as a training group to act on supervises is taken when a learner or a professional has demonstrated adequate competence. Now just think of in a traditional situation, here's a supervisor and there's a learner. And this is the psychology of the conversation. So the learner actually hopes to get a mark of superior. Well, the teacher thinks, she's actually nice, she works hard, I can't really find a reason to fail her, and it probably will not hurt her, and also it will stimulate her if I mark her as superior. So he might do that. Now think of the same conversation when you think of an EPA. Now the supervisor thinks, she is nice and she works hard, but it may hurt my patience if I mark her as ready for unsupervised practice tomorrow morning. They might even think of their own families and say, would I trust this person to work unsupervised with my children if they have been admitted and I'm not present there? That's quite different than they would have to just negotiate whichever score leads to all residents being above average at the end of training. Now, legitimate peripheral participation of learners in the community is also served by using that EPA approach. That terminology is taken from educational research. Among educators, it's a well-known phraseology, and you could just think of it like concentric circles. In the periphery of professional practice is where learners start, and what they need is to move to the center, at the center of the community of medical practice. And if you use EPAs in your program, it means that stepwise the learner can progress towards that center and become part of the medical community instead of only at the moment of registration. Now finally, EPA-based maintenance of certification or maintenance of competence. I showed you this graph, and it actually means that if you would define EPAs with, and it has been suggested in the literature to define it with an expiry date or expiration date, it actually would mean that if people show no practice after certification for an EPA for a specific, could be a procedure, a set of procedures, you might want to have them fall back at the levels of supervision. Say you are allowed to do it, but from now on only with direct supervision, or maybe indirect supervision available, but not completely unsupervised anymore. So that could be something that could be used in the maintenance of certification. Here's an example that was actually published in the Academic Medicine. It was more of a fantasy, but it shows the digital badge of someone in training with an EPA in Pap smear. And the nice thing is that the authors suggested here that there is an expiry date for that EPA. So if you have not practiced and have not revalidated, and it could be easy to do that if you continue practicing, it would be probably not very difficult to do that. But if you don't do that, you don't continue practicing, you might have to restart if you want to do that under some level of supervision. Here's some examples of how EPAs have been applied in practice. This is from a program that we have worked with physician assistants. It is an individualized 5 EPA neurology workplace curriculum for an individual physician assistant. And here you can see across their whole training period of 10 blocks where this physician assistant has reached that level 4, from which on they actually are scheduled to do work at that neurology department. Here's an example from a publication in Academic Medicine where the pediatricians have suggested a series of EPAs for pediatric residency. And you could also see that at PGY 1, 2, and 3, they have used the same levels of progression in supervision, and they also linked each of those EPAs to the competency framework that is used in the United States. Here is another example, very different example from my own school, and we're busy to start an undergraduate program for medical students. And our workplace curriculum has 5 EPAs, including the clinical consultation, general medical procedures, informing and advising patients and their families, communicating and collaborating with colleagues, and extraordinary patient care. You don't have to read everything, but it's for the students will make very clear and detailed what they are expected to do. And if we map that across our curriculum, let me see. You don't have to read this all, but what it designates, what it actually means to say here, that at the end of training, we will sign people, or in the last year of training, I should say, sign them off for these 5 big EPAs, and we'll pay attention to each of these 5 at different stages in training. For instance, if I take the example of the clinical consultation, we will attend at a clerkship on the gynecological or obstetrics, clinical consultation, pediatric neurology, psychiatry, and geriatrics at different moments. And at the final year, we'll all integrate that, and we expect our graduates all to have mastered that clinical consultation at the level, what we call the level of indirect supervision. There must be a supervisor available, but not in the room. That's the level that we expect all graduate for medical education have at the end of training. To wrap up, competency-based medical education is really a great advance, but competency frameworks are not always as practical as the experiences are. And trustable professional activities can give meaning to competency-based medical education by connecting competencies to practice. And trustment decisions deepen the nature of assessment in the workplace, and EPAs can be used to structure learning and teaching and assessments throughout the continuum of education and practice to serve not only competency-based medical education, but even competency-based medical practice. Thank you very much.